So I'm going to talk about some of the challenges in getting going with a PAD program. So vascular disease, when we talk about vascular disease and we talk about vascular interventions, we talk a lot about turf and turf wars and turf battles. You see some siloed care, different specialties. And, we talk a little bit about egos of different specialties and how do we manage these across different specialties that do similar procedures. So how do you get all these puzzle pieces to fit together? And this talk is kind of geared toward people who are employed in a health system like myself and some of the challenges I encountered. When you have multiple different specialties treating vascular disease, you come across some of these issues. How do you make them all work? So let's talk about multidisciplinary approach. We talk a lot about multidisciplinary approach, especially when we talk about critical limb ischemia. But let's talk about other parts of cardiology. So heart team, I'm a cardiologist. I do interventions in the coronaries, and if you see multivessel coronary disease, it's a class 1 indication to get a heart team together and discuss this. It involves an interventional cardiologist, a cardiothoracic surgeon, and you kind of decide the best approach for the patient. Valve team, I do structural heart disease, so I'm on, I am part of a valve team at my institution. We do a lot of TAVRs, MitraClips, and we have a very specific team. We meet once a week, every Thursday morning. We have a conference, and we go through all the cases that are potentially going to have a valve intervention. And we have different specialties there. We have the patient's non-invasive cardiologists, we have interventionalists that do the procedure, and we have cardiothoracic surgeons, among other people in the room. So how does this work with vascular disease? Is there a vascular team that should be coordinated for these type of patients that have complex disease? And if so, who does that involve? So let's talk about multidisciplinary versus multidisciplinary. So when you're talking about a multidisciplinary team approach with critical limb ischemia, we talk about these people. You talk about a wound care team that involves a podiatrist, ID doctors. You have nurses that help care for the patient. You have the primary care doc. You have nutritionists, diabetes educators, et cetera. And then you have a CLI interventionalist. And all these people get together to try to provide the best care for a critical limb ischemia patient. But what if you have multiple people at your institution, all employed by the health system, that provide this role here of the interventionalist? Interventional cardiology, vascular surgery, IR, other vascular interventionalists, and vascular medicine. So what does this create in a health system? I mean, if you have multiple people doing a similar procedure, oftentimes you can create siloed care. And what are the problems with that? So if you have a couple different people who might do this procedure that aren't necessarily coordinated with each other, you often have an overemphasis on procedures and maybe don't explore all treatment options if they have different skill sets and different specialties. You often have lower patient satisfaction due to gaps in care or maybe contradictory advice. Maybe the patient's cardiologist has a colleague who does this and says one thing, and then they end up seeing a vascular surgeon who says something else or provides a different procedure that the patient was expecting. And then potential missed opportunities for cardiovascular risk stratification. We all know that critical limb ischemia patients and PAD patients in general have poor cardiovascular outcomes. So how do you coordinate getting that patient to the right place and getting the appropriate care, making sure that their cardiovascular outcome is also optimized if they don't see a cardiac specialist? And so all this can lead to worse outcomes for the patient, which is not desirable, obviously. So let's talk about value-based care. We've talked about it a lot during this course, and it's something that's talked about a lot in the literature. Essentially trying to provide the best care and most efficient care for the patient in the best, most coordinated way. So in value-based care, collaboration is rewarded. Interdisciplinary competition typically is not. If you have a health system that employs specialists, collaboration between those specialists typically works best for a value-based outcome rather than competition. Efficiency and quality are rewarded. Those are the outcomes we desire, obviously leading to the best outcome for the patient. And then encouraging coordination of your talents, taking people within your institution and putting them in the right places to provide the best outcome for all your patients in your health system. So what are some of the challenges you encounter when you try to coordinate all these different specialties? So you have overlapping skills. This is something that's different than the coronary team, the heart team, and the valve team we discussed. In vascular disease, you often have a vascular surgeon that does endovascular care, and then an interventional cardiologist does endovascular care. Overlapping skills. You don't see that as much in the other teams. Fear of downsizing. If you start taking people that do the same thing in an institution and trying to coordinate them, you might say, look, we have 6 people that do this. We might only need 4 or 5. And people fear that if they if they relinquish any of their volume to try to collaborate, that their job could be eliminated. Misaligned incentives. If your incentives at your institution and your health system, your contracts with your physicians involve only an RVU-based system or only procedure-based reimbursement, you're going to have competition for procedures. And autonomy. Everybody who does vascular interventions probably thinks they do it better than anybody else, and so trying to collaborate and coordinate with that can lead to potential concern for loss of autonomy. And then there are interventionalists who say, look, my care is comprehensive. I don't need anybody else. I can provide all the care that I need for my patient. So how do we make this all work? So finding a place for all these interventionalists in one cardiovascular service line. So having a heart and vascular institute, a lot of our institutions have this in a health system that uses an employed model. This is very common. And placing vascular specialists in leadership roles and putting them as a priority for the institute, making sure it's not just a heart institute, but a true heart and vascular institute. And then close proximity. If your office is in one building and the vascular surgeon's office is in another, collaboration is less common, and it often creates a we versus them situation. Even close proximity by putting them in a same vascular center or vascular clinic can often lead to much better collaboration. So the key here is building trust and aligning incentives. So how do you build trust? Putting together a program in your health system that incentivizes value-based care. This is difficult, and it often leads to a complete relook at how you reimburse your physicians and how you treat your physicians. Shared accountability, making sure that everybody shares in the outcomes so that everybody wants the best outcomes for the patient. Regular vascular conferences, using these for education and improvement, having weekly conferences or monthly conferences to go through patients, go through cases with all the disciplines there, and trying to learn from each other and figure out the best course for the patient, not using that as an opportunity to showcase bad outcomes of your colleagues. Collaboration with training residents and fellows. I heard a talk during this conference where one of the cardiologists said that they share with their vascular surgeons, residents and fellows going back and forth and training with both, and they found that that was extremely helpful. And a lot of programs do not do this. And I think we can often learn from each other in different specialties. Set a high bar for quality, use metrics that matter, so you're providing good outcomes for the patients. Identifying individual strengths, identifying interventionalists in your institution that have certain skill sets and trying to coordinate that so that everybody it kind of optimizes their strengths. And then embracing new members. If somebody joins the health system that provides vascular interventions, if they want to do that, they're going to do that. And you can either fight that or you can embrace that and take them under your wing and say, look, let's mentor, let's work together, let's find a way to make this work for the best outcome of the patient and the institution. And then just put the patient and your community and your health system first. This is the idea behind value-based care. I think you'll provide the best outcomes for your patient. Thank you.